Still snoring is not us after lunch, so it is the children after adrenal tonsillectomy. A very good afternoon to you all. So I'll be covering the topic of children who come back after adrenal tonsillectomy with persistent symptoms for today. But before I start, I'd like to acknowledge my team, the pediatric ENT team, as well as the anesthesia, the NICU and the PICU teams. Without their support, this would not have been possible. So what's this noise all about? Why are we worried about post-adrenal tonsillectomy OSA? We know there is a high prevalence of OSA. I'm not going to repeat what's already speakers have spoken about. And the gold standard recommendation is do an adrenal tonsillectomy. So how does that now? What are the outcomes? So you tell a parent, you do an adrenal tonsillectomy, your child is likely to improve 60-70%, there's 30 to 40% chance of recurring. If the child is obese, it is somewhere around 10 to 25%. So you say your child needs surgery, these are the risks. So there is going to be post-op pain, there is risk of bleeding, but the surgery may improve only 10 to 25% symptoms. So as a parent, I would not agree to it. So that is the challenge with these recommendations. So again, the multi-center studies which say it's a small, the incidence or the prevalence of vestibular OSA is quite high. So what do we mean by persistent OSA? Again, the jury is divided. There is no unified definition of persistent OSA. If you look at this American Thoracic Society, they look at OAHI of more than 1 as persistent OSA. But if you look at other papers, they look at OAHI of 1.5. So there is a bit of ambiguity. But again, I think the intention is not to have ambiguity in definition, but to kind of move the threshold where we need to intervene, where something which is acceptable, something beyond that is not acceptable. So the question is, when are T's and A's likely to fail? So let's look at it this way. So persistent OSA. Obesity is an important risk factor. So severity of OSA, genetic, cardiopulmonary, neuromuscular, syndromic kids, very young or very old kids, and allergic rhinitis and asthma. We'll look at this one by one. We'll run through it. A lot of it is already covered. So obesity. So adrenal tonsillectomy in OSA, the likelihood of having a high OHI or a high residual OHI is high. So almost half the kids have an AHI of more than 5 post-adrenal tonsillectomy. Whereas if you look at the baseline severity, so someone who started off with a very high OHI before your adrenal tonsillectomy is likely to come back with residual OSA. So almost about 65% of these children with AHI of 1 pre-op are likely to come back with persistent symptoms. Again, genetic and syndromic, we had a wonderful speaker who shared about this is something what the New Zealand guidelines share, and up to 50% of residual disease in children with genetic syndromes and craniofacial abnormalities, in particular the Pierre-Robin sequence and achondroplasias. Then we have this a broad non-specific group of cardiac and neuromuscular. There is no exact number or statistics, so I can give you it, but these groups tend to have a higher residual OSA. Then of course age. Children who had adrenal tonsillectomy very young, or you're doing adrenal tonsillectomy in kids who have got the bony changes already which have happened, which I think Rosh is going to talk about later today. So their likelihood of having, and of course allergic rhinitis and asthma, that is something which is not so well treated. The risk of having residual OSA is almost double than someone without allergic rhinitis. So we've done OSA. These are two different kids. Both had adrenal tonsillectomy. So this is what their breathing is. So parents have come back. You've done a surgery. They're saying, doctor, you said my child will get better. This is my child. This is how he's sleeping. We are in a fix. It might be done by you, it might be done by someone else. But the question is, what is an ideal time to evaluate? So ideally, clinical follow-up should be within the next 6 to 8 weeks, and PSG in 2 to 3 months if necessary. And again, you look at both the New Zealand guidelines as well as there's a study from Middle East somewhere where they have said 4 months after surgery. Again, questionnaires. There are a lot of questionnaires what can be used. Again, these are not a replacement for a sleep study, but these are valid clinical tools what can be used in our day-to-day practice. But again, these cannot replace PSG. I reiterated. Overnight pulse oximetry, it is cheap. It can be easily be done. You don't need a expensive sleep lab, and of course limited channel sleep study. These are economic alternatives to layer one sleep study. So when to do sleep study? So in a child post adrenal tonsillectomy, this is the New Zealand guidelines which I'm sharing. So post adrenal tonsillectomy, what they recommend is in children without any comorbidities to do a clinical assessment at 2 to 3 weeks. If the child is 4 to 6 weeks, at 4 to 6 weeks, if the child is asymptomatic, no PSG. If the child is symptomatic, you have to do a PSG in 2 to 3 months. Whereas that changes in someone with comorbidity. So after adenotonsillectomy, you book them for a sleep study irrespective of the symptoms after 2 to 3 months. So polysomnography is the gold standard. It's already discussed. I'm not going to go into details. But coming again, DICE is something what we have extensively spoken about yesterday and today. So it is not again a replacement for PSG. So it gives us a different perspective. It changes our perspective. We look at the site and severity of obstruction and not the severity of the OSA. So these are two different perspectives to the same problem. So when do you do DICE? One is when you think there are other problems. CPAP is not desired or there is poor compliance. Again, the question is its relevance to the Indian population. We need to see because cost is a very touchy issue, especially for our patients. So you've done a surgery, you're telling the parents, you come back and do a sleep endoscopy, I will diagnose the problem and I do another surgery. So that is something which is challenging. So probably this discussion has to happen in children with these risk factors. Talk to them before you do an adrenal counseling. Unfortunately, if you get someone else's post-op patient, that's a different story. But if it's your one patient, you talk to them. It has to be shared. It's a shared decision that has to be discussed before you actually go remove the adrenal tonsils. So there are other investigations, CNA, MRI. Of course, most important one in these or other two important ones are one is the nasal endoscopy, so do an endoscopy to assess the airway, and second is of course the orthodontic evaluation. Then there is imaging biomarkers and all which are useful tools. So how has our evolution, our understanding evolved over these years? So if you look at the AAP guidelines in 22 and New Zealand guidelines. AAP guidelines said CPAP is highly effective. You give CPAP someone who's got post adrenal tonsillectomy OSC, don't break your head, give CPAP. But they looked at only kids without syndromes. Then one step forward, we have the New Zealand guidelines in 2015. They said give CPAP to syndromic kids also. It is one step further. So, but there are a lot of blind spots in these. These are based on data from very studies with small numbers, poor compliance, and they are not looking at the compliance rate. So that is one biggest flaw in this study. So then in 2024 we had the American Thoracic Society. So they came with a little more a step further. They said, in addition to CPAP, of course, they spoke about directed surgery, they spoke about medical management, they spoke about orthodontic and dentofacial treatment, and of course, weight loss and management. So this is CHAT study. We all have read about the CHAT study which was published in 2013. There was a secondary analysis of that in 2025. So they looked at the endotypes similar to the adult ones in here and tried to understand the endotypes. So what they came up with is, sorry, did I miss a slide? Okay. So it is again, this is the thing. So adenotonsillectomy is purely an anatomical intervention. So this does not really counter the muscle responsiveness. The collapsibility improves after adenotonsillectomy, but the muscle responsiveness does not. So this particular study in sleep medicine this year, so they looked at, this is what Srinivas was talking about yesterday, Mulhall study. So they divided kids into broad 5 phenotypes, but of course we will have children who are not fitting into any of these baskets. So there is need, there is a scope for further work in this area. And in this particular study, what they said was adenotonsillar tonsillar hypertrophy is omnipresent. So it has a high prevalence and there is supraglottic collapse in specific groups. So area to focus. You have fixed areas and bony areas or dynamic or soft tissue collapse. So the nose is often the elephant in the room. So we often miss the nose, like this particular kid who's got very congested cabinet. He's got big adenoids and big tonsils, that's a different story. But this one is likely to come back with symptoms. Nose is quite congested. And there is high incidence of allergic rhinitis. And we all know we already spoke about. And again, what this American Thoracic Society in their guideline, they spoke about lingual tonsillectomy and supraglottoplasty. So they say if your adenotonsillectomy fails, your surgical next step should be either a lingual tonsillectomy or a supraglottoplasty based on your dice. But this is a patient who's got supraglottic collapse on the left. Can you see that? On the right, it is the same patient with a nasopharyngeal airway. So we have bypassed the nose and the collapse is almost gone. So this patient was saved an unnecessary supraglottoplasty. If you followed the American Thoracic Society guidelines 2023, this patient would have needed a supraglottoplasty. It does not need a supraglottoplasty. The problem lies in the nose. So often it is the nose which is overlooked. We want to do fancy surgeries, but first look at the nose, then think of the other problems. Of course, the palate, avoid radical surgery in palate. Is it true? Yes. This is true in regards to radical surgeries of the past, like UPPP, which is no longer done. Now it is more very tailor-made palate surgeries. There is consensus statement on on persistent OSA, where they speak about lateral wall collapse and they speak about doing an expansion sphincter palatoplasty for children with OSA, so which is well supported. So it is not a contraindication, it is what surgery you do, that is what's contraindicated. Coming to dice directed surgery, this is a 10-year-old with Towns, lingual hypertrophy. So this kid definitely needs a lingual tonsillectomy. This is not something which is because of the nose. And coming to tongue base, complications of lingual tonsillectomy is quite identical to post-adenoid tonsillectomy in regards to pain, bleeding, and other complications. But of course, you have to take it with a pinch of salt. The risk of lingual artery bleed is high, so you have to be a bit careful. How I do it is I use a ultrasound, do a transoral ultrasound, the hockey stick probe, tag where the lingual artery is before I do. But of course, you get these odd branches, so you need a coagulator to do these surgeries. So this is again a child with an epiglottic collapse. So just speed it up, we're not interested in notes at least at this point. So you can see this child has a floppy epiglottis. So he will need an epiglottoplexy. So the problem with even putting him on CPAP is further going to push down the epiglottis. CPAP is counterintuitive, it will worsen his voice. So he needs something to pull the epiglottis forward. Again, orthodontic treatment, Roshan is going to talk about it. I'll just skip it, I'm running out of time, I think. Of course, there is a white paper by the American Association of Orthodontics. This is, I'm not trying to say that they're trying to discourage doing orthodontics. They came up with a revision also update this year. It is about the malpractice what was happening in US. So it is about more billing where orthodontics were trying to do stuff without actually doing it as part of a multidisciplinary treatment. There are a lot of points what they have come up with. If you read the full paper, it is much clearer. I think Roshan is going to touch on it. So of course, hypotonia. I think about last couple slides I've run through. Hypotonia, these syndromic kids who have hypotonia, Prader-Willi, Down syndrome, only 20% have resolution post-adenoid tonsillectomy. So it's a good idea to have a chat before you do surgery on these. In children with CP, there are these nasopharyngeal stents which have been tried successfully as an alternative to CPAP. This is a small case series of 4 patients only, but that is something what can be done. Of course, CPAP at the end of the day is gold standard. It helps, but our intervention is required where children do not tolerate CPAP, are not compliant. We probably help reduce the pressure, make it more acceptable. And take home message, do not forget the nose. I'm happy to take any questions if you have any.
I do have any.
Very nice presentation, sir. And What about all the effects are post onset? Maybe if the patient is having the snoring or something, the symptoms is still persisting. Your doctor is verified. What about the preoperative? When you see the child is non-symptomatic. Usually we don't we won't do imaging also for that patient. After seeing this presentation, it's thinking that we have to do some more investigations or diagnostic protocol to safeguard ourselves.
That's a challenging question, sir. So if you look at this phenotyping, so the endotype what this paper says, sorry, yes. So this 2 to 12 year group is the ones who have very good outcomes. So if your patients are in this age group, you don't need to worry too much about it. It is the other endotypes which are more problematic. So you need to be a little cautious if you have children under 2. You have obese children, which is becoming quite more common these days with all the fast food and all that, and of course syndromic kids.
The cardiac evaluation is needed for the case posted. Cardiac evaluation is needed for the case posted.
In syndromic kids, yes. If you're doing probably depending on what syndrome the child has, you might need a cardiac assessment. It might not be a blanket rule, one size does not fit all. Everyone might not need a cardiac evaluation. There might be syndrome specific who need a cardiac. If they have Down syndrome, definitely needs a cardiac evaluation before you take up first delivery.
Like past close, like adrenaline noise is sufficient for a kid of 6 to 7 years. After your presentation,
Thank you. Direction where we elevate the flap on one side, excise the deviated most part, avoid touching the growth the areas along the maxillary crest and the polycardial junction. We tell them that he may need a second surgery on his past is in his teens, but this is something temporary. But of course, turbinate is also something we can work on.
Regarding the recurrence of adenoids, because usually we remove the maximum, but to prevent it, you can maybe do with sprays or something like that, or we have to what we have to advise the patients regarding adenoids recurrence.
So usually adenoid recurrence is something which takes time. Usually the regression starts after age 6. So but up to age 6 it grows. So always talk to the parent that there's a small chance that adenoids may grow. But endoscopic adenoidectomy, as long as we are clearing the coena and the eustachian tube area, even if it grows to some extent, the symptoms will be far less severe. It is the coronal obstruction which causes the obstructive symptoms and the eustachian tube obstruction which causes the media symptoms. As long as these areas are well cleared under vision, so that's where all the population and suction diathermy and defibrillator come into play.
Thank you, sir. Wonderful.
Thank you so much.
Thank you, Kamran. One comment, Kamran did tell you that about whatever you data was presented, who will still have some sleep disturbance, but he used the word obstructive sleep apnea. We actually did a thesis on us, on our PhD on table, and we had PhD children or something. At the end of it, we had 3 months follow-up, we did a scoping and sleep evaluation, not by pediatric OSA, but by questionnaire study. 25% of them did have some sleep disturbances, in spite of the adenoids being less than 1. So there is a subset, and none of these patients were syndromic, so don't worry about it. So that is there, it is there. So more to be done.